All right, so inflammation, all right? I'm going to try and keep this, most of us have had immunology before. This is one part of immunology. The chapter 3 goes into immunology also. These kinds of things I do just a tad bit more than other things because immunology is one of those subjects that most students, I'll put it bluntly, hate. Okay, it's just all over the place. Although if you just had microbiology, it's probably fresh in your mind. Okay, but it's usually taught in A&P too. So I'm going to keep it short but sweet, but I want to get into the different types of inflammation, and we'll finish it off by doing repair. The repair shouldn't take too long. All right, so we have 3 forms of defense when a bacteria comes in. All right, think of your house. You got a picket fence around there, and that picket fence is the first line of defense. That tells people, whether it's Aunt Tilly, the mailman, a burglar, that that's private property. That's the first thing that's going to block off good or bad people. Okay? They would choose to come in. Well, guess what? We got this to deal with. We got Fido, the dog barking. Again, Fido is going to bark at anyone that walks through that gate, whether it's Aunt Tilly or mailman or a burglar. What I'm saying here between these two things, the picket fence and the dog, that's non-specific. That's the innate immunity, right? It's nothing specific, whether good or bad, okay? It's not until here where the master comes out of the house saying, "What's all that racket over there, Fido? Oh, that's Aunt Tilly. That's okay. You can lick her leg. It's fine. She'll be fine with it. Oh, that's a burglar? Keep on barking. Bite his. I'm going to call." He's more specific. He can tell if it's bad or good. You see the difference? All right? So these are 3 lines of defenses. These first 2 is going to be the innate, and this last one is going to be more adaptive, okay, more specific. So we have the innate, which deals with these things here, including an inflammatory response. So an inflammatory response is going to happen whether good or bad things come in, okay? Then we have the more specific, which is going to deal with antibodies and cell-mediated stuff, right? So this is more about chapter, I'm just going to talk about mainly this stuff here, but this is the chapter 3, okay? So these are all the natural immunity stuff, right? You went all through these different things over here, kinins, prostaglandins, all that. I'm going to go over a few of them. But this is all the adaptive. This one tends to be the easier of the 2. There's more things here. That's more memorization. This kind of becomes a monster. You deal with helper T cells and all this stuff. Okay? All right, so inflammation, all right, part of the non-specific immunity. So why is it a good thing to be inflamed? Why is that a good thing? Well, it walls off the area of injury, all right, so that the good stuff doesn't go to that area, right? It kind of walls it off, and it also prevents anything from that bacteria can spread further. So we got to do that. And it's also to initiate the repair process that we're going to talk about too. Okay? So that's why this inflammation is important, that it does occur. All right, acute inflammation happens hours to days. All right, responds very rapidly. And we have a chronic inflammation, we talk about weeks, months to years, and this is where a continuous cell damage occurs, and we're going to have organ dysfunction. All right, it happens for a long amount of time. All right, it usually inhibits healing too. It heals and stars, and or heals and reinvents itself and heals, and it just keeps on going in a big loop. So cells of inflammation, right? You got the neutrophils, you got all these white blood cells, right? You learned all about these. You do need to know the percentage ranges. Hint, hint. Okay? Make sure you know those. Remember I say hint, hint? It's usually a question on what's going to happen, right? So you need to know those percentage ranges, because if I said to you an increase of, if an eosinophil count is 12, that means that there's what? Is that normal or not? Or does that mean that there's an infection going on? Like, you need to know what that is. These are the different types of macrophages, right? You talk about those. Natural killer cells release perforins to destroy cancer cells and virus-infected cells. And mast cells are similar to basophils. They're going to release heparin and histamine. And mast cells, they don't wander in the bloodstream, but they more or less live in CT, which is connective tissue. Okay? And platelets, do make sure you know what the normal range is. And the range is what you need to know, because some of them are very tight. You need to know those. Neutrophils, we have polymorphonuclear leukocytes, or better known as PMNs. Okay? These are mature neutrophils. Okay? They're basically the same thing. But then you also have bands. I never heard this. Your book refers to them as stabs, but bands is what I heard. Different word. But these are immature neutrophils. If I see that there's a lot of neutrophils and there is a lot of bands, that's telling me there's a new infection going on. Bands, there's new immature ones. There's a reason why. There must be a new infection going on there. So we say something to it, and if you look at a lab report, you'll see what I mean by shift to the left or shift to the right. But just understand that if someone says there's a shift to the left, that means there's an increase in bands. Okay? This indicates that we have newly formed neutrophils being made. Must be something going on. If there's a war going on and you're recruiting more army men, that's why you're recruiting more army men. It's because there's a war going on, right? It's the same thing here. So if someone says that there's an increase in white blood cells with a shift to the left, you know that there's an acute inflammatory process going on. That's what you're going to hear. Okay? Chemicals of inflammation. There's some things that are actually coming from the blood, the plasma. The complement system, that's where opsonization, inflammation, and lysis occurs. What is opsonization? What is that? That enhances what? Phagocytosis. All right? Yeah. It enhances phagocytosis. So it makes sure that that goes on. So it does opsonization, inflammation, lysis. So OIL, it's a complement can of oil. You want to say that, right? OIL. Kinins is going to do vasodilation and increase capillary permeability. Clotting factors are going to do things in here. There's also some things that could get released by cells themselves, cytokines, and all these different things, interferons, TNF, all the stuff you should have learned from micro and AMP2. Histamine causes vasodilation, also increased capillary permeability. When that increases capillary permeability, it's going to open up the cells to allow more white blood cells to go out there. But water goes out there too, right? If you're going to open up those cells in between the epithelial cells, if it opens them up, water's going to go out there, right? Heparin is going to decrease blood clotting so that cells can get there. It becomes looser, the blood, so there's no blockade going on there. Prostaglandins. Ooh, there's a whole list of prostaglandins. I'll show you something about that. So that'll cause those things. And nitric oxide, we talked about that earlier. Okay. So prostaglandins regulate, they do these wonderful different things over here. When you get to pharmacology, I'm not going to ask you this at all, so don't worry about this. I'm not going to ask you about any of this. This is like an FYI. Where does aspirin, where does corticosteroids affect this? You might want to save this slide when you get into pharmacology, because this is a brilliant slide over here, and it helps you understand it. But I won't ask you about the mechanisms of medication, okay? This is just an FYI. Inflammatory response to injury. First, you have a vascular thing happening, and then cellular. So what happens first, think of motor vehicle accident. You see on the road a motor vehicle accident happens, okay? Do you guys have to go? I know it's like quarter after. It's fine. You don't have to be here. It's okay. I'm going to record it. I don't want you to have to be someplace. I'm not going to knock off any points or anything. You guys want to stay? Yeah? Okay. You have to go. That's fine. Okay? All right, so what happens here is that first you have a vascular change, and then you got a cellular change. If there's a motor vehicle accident that happens, the first thing that you're going to do is, it happens right in front of you. You stop and you shake up, like, whoa, you feel your heartbeat and all, right? So you're going to have this, which have vasoconstriction first. And then you're going to drive around it so you get out of there, right? So you have this vasospasm first, and then the doorways open up and a lot more blood goes in that direction, a big blood flow. Does that make sense? Okay? So you're going to have this very quick vasospasm first, and then you're going to have the vasodilation. Now, what happens is you turn 2 lanes into 4 lanes. So when that happens, are you going to have more blood go into that area or less? More, okay? If more blood goes into there, red, what happens to the color of your skin in that area? It becomes redder, right? Pinker. When you think the next time you get an inflammation that's happening someplace on your body, okay? You're getting grown toenail, whatever. It becomes redder because more blood is going there, okay? When you have more blood going there, we refer to it as erythema, a redness to the area. And because blood is a ½ degree higher than the rest of your body, it also, with the back of your hand, you feel it, it's warmer. So you have that warmth that happens there. It swells up because there's more blood going into that area. We call that edema, localized edema that happens in that area there, okay? Cellular response, what happens is that you have the white blood cells. Now you open a doorway, right? You're opening it to 4 lanes so the ambulance can get over there. So the white blood cells can get to where that car accident is. So it's going to bring more white blood cells there. And they're going to open up the cells in between, or the area in between. Your cell wall has made up of these epithelial cells. They open up, allowing the white blood cells to squeeze on out of there into the tissue where, I don't know, you stepped on a splinter or something like that. So we call that diapedesis, okay? And it squeezes out over there. How does it know where to go once it goes into tissue? Well, at the place that you stepped on that splinter, there's macrophages that are doing their job over there, but they're releasing chemicals to kind of like a popcorn trail. It's going to release popcorn over there, and the white blood cells follow the popcorn to the area. We call that chemotaxis. It's a chemical area where they could actually follow that pathway. So here you have the white blood cells. Okay, they can squeeze out of here, diapedesis. Okay, and this is where the rusty nail came in, and this is where the big area of action is happening. Right. So we're going to have macrophages here. They're going to release chemicals so that when the white blood cells come out here, they just follow the popcorn trail. That's called chemotaxis. They follow the popcorn trail to where it is. Otherwise, if they don't have the chemicals here, they're just going to wander in different areas. But they are attracted to those. We call it chemotaxis.
The inflammatory response is an important nonspecific defense against tissue damage. It begins when injured tissue cells release chemical signals that activate the endothelial cells of nearby capillaries. Within the capillaries, adhesion molecules called selectins are displayed on the activated endothelial cells. These adhesion molecules attract neutrophils, slow them down, and cause the neutrophils to roll along the endothelium. As the neutrophils roll along the endothelium, they encounter chemicals that activate integrins, which are adhesion receptors on their surfaces. These integrins then tightly attach to adhesion receptor molecules on the endothelial cells. This causes the neutrophils to stick to the endothelium and stop rolling. This accumulation of neutrophils along the walls of the capillary is referred to as margination. The inflammatory mediators released by the injured tissue bring about changes in the environment that cause mast cells to degranulate and release histamine. Histamine causes vasodilation and an opening of the junctions between the endothelial cells, allowing fluid and leukocytes to leave the capillary and enter the infected tissue. The neutrophils now undergo dramatic changes in shape and squeeze through the endothelial wall into the interstitial tissue fluid. This process is called extravasation. The neutrophils, followed by other types of phagocytes, are attracted to the damaged site by chemotactic substances released by bacteria and tissue breakdown products. They ingest and destroy invading bacteria.
Okay? And you could do those steps over here if you want. Okay, how we got to that. All right. So there's your cardinal signs, the ones I just talked about, right? Rubor, erythema. What is rubor? Spanish people? Or people who speak Spanish? What is rubor? Red? Yeah, that's red. Yeah, so it's rubor. So it's red, right? Tumor is swelling. All right, tumor swelling. Color, warm, hot. Dolor, pain, right? And then loss of function. Now, I didn't do this because I'm trying to show you my medical Spanish happening over here. This is what they call them, but I'm just converting what they mean. The color, this is what they say is what is derived from. Okay? So that's, you need to know those. You could use this little picture to show the 5 different things that are happening over here. It's just another picture showing that. Okay? All right? So from a tissue injury from a piece of glass that you just cut yourself, what is your body, how does your body adapt with the heat, the redness, the cardinal signs that are happening over here until healing? Let's go step by step. This is not to overwhelm you. This is actually to help you a little. It kind of puts everything that we just talked about into one picture slide. And guess what the next step is, the next step. If you read my syllabus, the first part, the introduction, it's all about telling a story. You know, don't just memorize that tissue repair leads to this. You gotta know the whole story, how to go about this whole thing. It'll go faster and faster once you do all this, and it's much faster to do in your head than for you to speak it out. All right, so acute inflammation versus chronic. Okay, acute inflammation follows a brief injury. All right, hours or days, usually resolved without scarring. Okay, the phases of acute inflammation. First, you get this quick vasoconstriction, and then this prolonged vasodilation. Just what I talked about before. Okay, you're going to get vascular wall changes, migration of the neutrophils, so the neutrophils can line up and go outside into the tissue to where that infection is happening. And then you have this accumulation of exudates. Remember, exudates is a substance that the cell releases into the extracellular fluid. Okay? So this exudate contains proteins and clotting factors, and AB is antibodies. All right, so we have that over there. This exudate is going to dilute harmful substances. Right? So if you have a lot of concentrate, there's a splinter there, and there's bacteria there. If you take the bacteria, now you put a lot of fluid out there, it's going to dilute that a little bit so that if the bacteria is releasing exotoxins, you're diluting it, so it's going to do less of the trauma that's going on. Plus, what's going to happen too, it's going to bring in large quantities of oxygen. There's a lot of activity going over there, so you're going to need a lot of ATP. So we need to make sure a lot of oxygen is at their disposal so we can actually make ATP and have all that activity going on. Okay? Characteristics, macroscopic findings is, when I say macroscopic, think what you can see with the naked eye. Right? Those 5 cardinal signs, the redness, the warmth, all that stuff, the swelling, the swelling, the pain, and not functioning. All right? Microscopic findings, you see the cells are injured. You will see also the capillaries are dilated, and you will see an increase of neutrophils. Okay? Think of those bands. Think of an increase of white blood cells and a shift to the left that I talked about. Okay? Okay? And this is showing you those events in a picture form. And also the sequence of events in terms of days, what's happening, and then where the neutrophils come in. Again, just do this. These are not to hurt you or hinder you, just to help you on this, make your life a little bit easier. Resolution of acute inflammation, most will heal quickly unless there's an abscess, then we got to do some other things. Complete resolution usually occurs, but sometimes, depends on how severe it is, there might be some scarring involved with that, or repeated acute inflammation. Okay? It can lead to chronic inflammation too if that stimulus persists.
Inflammation is the protective reaction of vascularized tissue to local injury. Acute inflammation is the early, almost immediate reaction of tissue to the injury, and it is the first phase of wound healing. Acute inflammation can be triggered by cell or tissue damage or by the presence of dead cells or noxious agents such as bacteria. Acute inflammation typically occurs before the immune response becomes established and aims primarily at removing the injury-causing agent and limiting the extent of tissue damage. Acute inflammation occurs in two overlapping stages, vascular and cellular. In the vascular stage, arterioles and venules near the site of injury constrict briefly, then dilate. Dilation promotes congestion, while an accompanying increase in capillary permeability leads to the movement of fluid into the affected tissue, resulting in the 5 classic signs of inflammation: redness, swelling, heat, pain, and loss of function. As fluid leaves the capillaries, the blood remaining in circulation becomes more viscous, it flows more slowly, and clotting occurs. The cellular stage of acute inflammation is initiated by the movement of phagocytic white blood cells, or leukocytes, into the area of injury. The leukocytes begin to adhere to the vessel wall, and then, in a process called emigration, squeeze through the wall and move into the inflamed tissue. The leukocytes wander through the tissue, guided by chemical signals in a process called chemotaxis. The cellular stage culminates in the leukocytes engulfing and degrading the bacteria and cellular debris in a process called phagocytosis. Products of phagocytosis, along with plasma and blood cells, form exudates, which accumulate, causing swelling and pain. Exudates are composed of serous fluid, red blood cells, fibrinogen, or tissue debris, and white blood cell breakdown products. Concurrent with the events of the vascular and cellular stages, chemical mediators release bioactive agents that act to mediate the inflammatory response. Mediators are derived from the cells or from plasma. One of the first mediators of an inflammatory response is a cell-derived mediator, histamine, found in high concentrations in the mast cells of connective tissues adjacent to blood vessels, as well as in blood basophils and platelets. Histamine is released in response to a variety of stimuli and causes dilation and increased permeability of capillaries. Serotonin, another cell-derived mediator, performs similar actions. The 3 major plasma-derived mediators are present in the plasma in precursor forms that must be activated, usually by a series of proteolytic enzymes. The kinins increase capillary permeability and stimulate pain receptors. The clotting system traps exudates, microorganisms, and foreign bodies. The complement cascade causes vasodilation, promotes leukocyte chemotaxis, and augments phagocytosis. Acute inflammation comprises a variety of complex protective responses to injury that, together, lay the groundwork for the next stages of the body's recovery: immune response and tissue repair.
So chronic inflammation is persistent or repeated moderate injury. Could be due to an autoimmune disease, infection, or any exposure that's just persistent to be causing these areas. This takes weeks to months to years. Okay? It's less intense than the acute inflammation. Your body is adapting to it. So it's not as intense. It's not painful as it was before. Okay? So it's a mixture of ongoing inflammation and repetitive healing. That's why the tissue tends to be a little tougher when you feel those areas. Okay? So we have macrophages and lymphocytes that are kicking in. We don't see much neutrophils because that's more of an acute thing. We see a lot more macrophages and lymphocytes. That's usually ongoing. We're starting now getting into T cells and B cells that are developing over here. Okay, so you do get the 5 cardinal signs as we saw with the acute one, and in this case you get the injured cells, dilated capillaries, but instead of the increase of neutrophils, you're getting an increase of lymphocytes. For that same reason, I want you to know the percentage ranges in those types of white blood cells. Okay, so that you can pick up if you have too many of this or too little of this, and you have an idea of what's going on. Okay. We could also have something called granulomatosis inflammation. I don't want to get too heavy in it, but it's a unique type of chronic irritation or inflammation that macrophages start developing around the necrotic area. And the best example of this is we see tubercles in tuberculosis. When we get into respiratory diseases, you'll see that. It's kind of necrosis that's happening in the center, but then you have this wonderful walled off area so that the immune system can't get into it. And you'll see the pictures of that. Okay, so it's a unique kind of inflammation that goes on. So if we have inflammatory effects beyond the injury site, some systemic effects that happen. Okay, first off, we have a fancy word here, lymphadenopathy. That's a nice $5 word, right? Lymphadenopathy. Lymphadenopathy, okay? So basically, lymph nodes, so lymph and then adeno is like gland, but we could use that as node. Opathy is disease. So basically, lymphadenopathy means an enlarged lymph node. I use LN for abbreviation. And it's due to some kind of immune activity that's increased in the lymph nodes. You have a cold, and people say, oh, I can feel lymph nodes over there. They're enlarged. Because you just had a cold. It's doing what it's supposed to. Okay, does that make sense? It's usually due to that. Okay, it could be, you may or may not have pain over there. But keep in mind, too, it may not be because of an infection. We also have to be concerned about lymphoma, Hodgkin's lymphoma, that there's cancer in there, too. Now, I don't want you to get scared. I don't want you to think, oh, my God, I got an enlarged lymph node here, I got cancer. Chances are, did you just get off of an infection? That's probably what's happening. Let's see if it goes away in a week or so. Does that make sense? All right, you got to think that way on that. So other systemic effects, the liver. The liver, there's a couple things I want you to know here. It releases something called C-reactive protein. And believe it or not, we also call it as crap. Okay? This is a reliable marker for any inflammatory process. And that's the problem with this. It's reliable, but it's not dependable because it just tells you it's any inflammation process. So that means it's non-specific. It increases during cancer, stroke, myocardial infarctions, any kind of infection. So I don't really use it myself unless I have no idea what's going on. This person's got a fever. It'll be likely, if I see, let's say, crap is low, then chances are I'm not thinking of these things. I'm thinking of something else. But it doesn't tell me specifically what it is. Does that make sense? It's non-specific. But it does help a little bit about what's going on. Now, the other thing, which isn't in your PowerPoint, but I added here, what I want you to know is it releases fibrinogen. Now, this is an interesting one, too. All right? The fibrinogen causes the red blood cells to settle rapidly in plasma. So in other words, when they take blood from you and they see how fast the red blood cells sink down because of the fibrinogen, that tells us that there is what we call an increase in the erythrocyte sedimentation rate, right? Sediment is the hard stuff, the cells themselves. And if we actually see it go really fast down, and they time it with this, then we say that that's an increased ESR. Again, ESR is highly nonspecific, but it may help if you have no clue what's happening with someone. This is increases in inflammation, cancer, stroke, myocardial infarction, and so forth. All right? So you should know what an ESR is. You should know what CRAP is, C-reactive protein. Because as a nurse, if you're going to, if a doctor says I need to have these kinds of things, checkbox and I need blood on these, you're going to see ESR. You're going to see C-reactive protein, you're going to need to know where they would be found on the sheet that you're going to have to draw that blood from for the person. Does that make sense? So I don't want you to not know these, okay? But I don't want you to go into detail about them, okay? But I might pop these words up later on with other diseases, okay? And you could also have brain effects with inflammation over here. You get a fever, you have malaise, drowsiness, loss of appetite, okay? Just things that the brain affects over here. So let's just talk about fever, okay, and what that means, why that happens. All right, what happens here is that pyrogens get released by white blood cells and macrophages when they get exposed to some sort of foreign substance. It could be a bacteria. Now, fever is defined, and you should know this, hint. Fever is defined as a temperature of 100.4 or higher, okay? If someone's got a temperature, what's a normal temperature? 98.6. But is 99 normal? 99.0? That's normal, okay? There is a certain range of normal values too, okay? You know, sure, you see 100.3, but to me, that is not a fever until they reach 100.4. I don't know, maybe the person just drank hot tea. I have no idea. But until it reaches 100.4, that's when I'll give the Tylenol to bring it down, okay? Now, that's what a fever is, and that's where you would actually talk to, you know, when you become a nurse, you're going to be talking to your doctors. They want to know if it's, you know, 100.5, you got to let the doctor know because he wants to get the temperature down, okay? Now, high fevers are dangerous, obviously. All right, and a high fever is defined as anything higher than 102. That's where it's going to start breaking down. The heat of your body is going to start breaking down enzymes, and those enzymes are just not going to function well, which means you can't break down and you can't make ATP. That's why when you have a fever of 102, you feel tired and weak because your enzymes are not working. So this is where it's dangerous. Okay? But moderate fevers, anywhere from 100.4 to 102, that could be beneficial. Although you don't want it to creep up to over 102, so I would still give the Tylenol. Okay? If you have these moderate fevers, it's going to increase the liver and spleen to sequester what we call iron and zinc. These two things are needed by many microorganisms. So you're taking that important stuff away from the microorganisms, and the microorganisms, well, the bacteria, whichever, can't do their things because you just took away their food. So in that case, that's what's going to happen. It also increases the metabolic rate to speed up tissue repair should that have happened too. Okay? So questions about that? All right? Now, one other thing. What causes chills with fever? Why do you have the shakes when you have a fever? Very easy to understand it. What happens, the part that you probably don't know, is what happens is certain infections, now you told me 98.6 is a normal body temperature. That's what your set point is in your brain, 98.6. But certain infections is going to change that normal setting to, let's say, 101. So now it changes to 101 as what your normal should be. Does that make sense? So you're at 98.6, and now the new norm is going to be 101. So your body has to adapt to that, change it to get it to 101. So how does it do it? You start getting shakes. Your muscles start contracting and producing heat to get your body temperature to this new norm. So you give Tylenol to get that new norm back down to your old norm so that you don't have the shakes. Does that make sense? Right? Okay? So in a fever, that's what happens. Your change in the body temperature goes up because of this infection. Okay? And then what happens is your blood vessels will start constricting. Your body will go through these shakes. The muscle contractions happen to produce this extra heat to get it to that point. Okay?